Welcome, everybody, to the Illusion of Consensus podcast. I am absolutely delighted to have here with me my good friend, Marty Makary, who is a professor in the medical school, a surgeon in the medical school at Johns Hopkins University. Also a health policy scholar in the business. Marty, what have you not done with your life?
Just hanging out and enjoying friends like you, Jay.
Well, we're going to have to do more of that. So the reason why I invited Marty to the podcast today is that he has has already published a new book with the title BlindSpots, and he gave me an advance copy. And and Marty, I confess I couldn't put it down. It's a weirdly compelling page turner of a medical nonfiction book. If I don't know how you pulled it off, my friend, but it was fantastic. And so I'm really glad you came to talk with me about it.
Yeah, thanks for your interest in the book, Jay. I was going to put a special scratch and sniff on the front just for you.
You know how to reach me, Marty. So now the topic of the book, BlindSpots, is actually quite a serious topic. It's that on item after item after item that medical professionals think they know the answer, they often turn out to be wrong. In fact, like I remember from medical school, one of my favorite professors was actually, he told me this. He said, "Look, we're teaching you all this stuff, but half of it's wrong." And I asked him, "Well, which half?" And he says, "I don't know." I mean, so I think that's the theme. How did you get into this? How did you decide to write this book, Marty? Because it's actually quite a brave thing for a practicing doctor to do that.
Well, groupthink has been around for a long time. And all of modern medicine, the last 10, 20 years that I've been in practice, you see it everywhere. Medical dogma looms large, and there's no scientific evidence to support it. So people are using their best judgment. Doctors are using their clinical wisdom. But instead of seeing an open discourse around many of the issues in medicine, we're increasingly seeing a small group of people at the top make decisions for everyone, broad health recommendations. And it's the story of chronic disease in America, the food pyramid, the dogma that opioids were not addictive. These mistakes ignite giant health crises. And at some point, you have to take a step back and ask, could it be that many of our modern day health crises have been caused by or hastened by the hubris of the medical establishment? We watched obesity rates soar as we moved the food industry to a low-fat, high-processed, refined carbohydrate diet. We ignored sugar. We today have giant blind spots, ignoring the role of pesticides and microplastics and seed oil derivatives and the refined flour that's basically converts wheat to sugar, like refined sugar. And that's the entire diet as we're watching all these chronic diseases go up. So, I grew up, as I told you before, Jay, in rural Pennsylvania, in the coal mine region of Pennsylvania. Now, my parents were not coal miners. My dad was actually a hematologist at the hospital. And I remember my mom taking me to the mall, and I saw smoke coming out of the ground along the highway. Now, the mall's only 15 minutes away from our home. And I asked her, "Mom, what's that smoke that's coming out of the ground?" And she says, "Oh, that's the Centralia mine fire. It's been burning for decades, and they can't put it out. It's miles long. It's going to go on for hundreds of years, and it's burning coal." And I thought, I was a young kid, and I'm like, that's interesting, I guess. But I guess, I don't know what the control group is, how other people live. I guess everyone grows up with a mine fire emitting toxic fumes. And my dad would notice all these cases of rare leukemia, all this rash of rare leukemia cases that other hematologists were not seeing at the proportion he was. So I assumed, like, oh yeah, Dad, somebody's putting the two together, right? This is causing it. And he's like, oh no, actually no one's looking into it, but hopefully someday they will. And you go to med school, you go to residency, you get embedded in the ivory tower of academic medicine. You realize nobody is asking the big questions. Same is true for the rise in autism and the declining fertility. Puberty is happening earlier and earlier each year. Half of our kids are obese. In my field of pancreas cancer, we have the biggest pancreas cancer group in the country. And we have, I would say, the best experts in the field of pancreas cancer. We do more than any other hospital. And at one point, I asked, does anyone know why pancreatic cancer has doubled in the last 2 decades? It's increasing. What's happening here? And not a single person, not only did no one know, no one had really even thought of the question. And you realize there are these giant blind spots, that these things no one's talking about that we need to be talking about, that are central to health. These are like the number one issues in health. And instead, we're kind of busy and, we put our heads down, we do the job that we're told to do. And at some point, we have to zoom out and ask these big questions.
I mean, that was part of my motivation for doing a PhD and not going into clinical medicine after I entered the MD. I thought I went to med school completely naive. I thought once I got in med school that I would be offered the wisdom of the ages, the secret to how the body works. And then and I got to med school and I'm like, we really don't know as much as I thought we did. Right. We know a lot. I don't want to downplay things. Yeah. We are, but it is the case that there's a lot of mysteries. And when you talk to other doctors, they recognize them as mysteries. Yeah. They may even have some curiosity about it, but in the literature and in the sort of dogma that overlays medicine, you're not really allowed to think about those mysteries.
We take bright, creative young minds who think big. The students that are coming into med school are altruistic. Like 90% want to do missions, if not as their main job, as a part of their practice on the side. They're creative. They got all these rich experiences. They're at the top of their game in biomedical engineering. And we take these bright, creative, altruistic kids and we beat them down with this robotic culture. We force them to memorize thousands of drugs and memorize indications and recite them back. We make them memorize all this useless stuff, like the forced memorization of the names of the molecules in the Krebs cycle. And we do it again and again. And
I think I remember one chemical from that, glucose 6 dehydrogenase. Just for the
well, that's one more than I remember. It's like
I might be wrong, though. I might be wrong. So those listening can check me.
But I had the same experience you did. When you mentioned you went to get your PhD, I kind of walked out of med school after 3 years of it. And I'm just like, what are we doing? And I enrolled at the Harvard School of Public Health and got a degree in public health. And eventually I missed the patient bedside care. And I went back and did a surgical residency and fellowship. But the dismissive nature of the big questions, the way we would convert students and later residents and attending physicians from these curious, intellectually curious people who want to focus on health. And we say, no, put your head down. You got to get an NIH grant on some small, incremental little discovery in a narrow field of medicine that's on the back end of care. It's the late stages. It's how we medicate or operate. It's not really on how to prevent these things. And we give them this crazy treadmill to be on where they've got to bill and code in short visits. And we monitor their progress with these RVUs, these relative valued units. Literally units that they assign to our work so they can track, how much busy work we're doing on the back end of care without addressing the root causes of what brings people to care.
That description is very bleak. But unfortunately, I talked to so many physicians who share exactly that viewpoint because it's true. That's exactly what the practice of medicine feels like for so many doctors today. And the natural curiosity that doctors have, it gets squashed, as you said. Yeah. And what happens then is that as a relatively small number of people at the top of each, it doesn't have to be the same people. It's not one Tony Fauci who can say, I am the science and that controls all of medicine. No, it's every field has its Tony Fauci.
Yeah.
Every field has its small number of people that control the dogma. And then, if you get NIH grants, one of the things that one of the taxes of getting an NIH grant is that you're invited to be on the review panels for other NIH grants. And you think about that and you say, okay, well, that makes sense. But, for a long time, the NIH required you to have an NIH grant to be on the review committees for future NIH grants, think about what that does. What that does is it makes sure that the set of people evaluating new ideas have a vested interest in making sure that the new ideas don't contradict their ideas. And they're the ones that are in essentially, I mean, if power is the right word, in power over the dogma of their little discipline.
That's exactly right. We've done a terrible thing to doctors in the United States. The medical establishment has said, you come in with these big ideas, you want to address health and the root causes. No, you put your head down, you bill and code and maximize throughput, and you can only deal with the late stages of medical, of a patient's health journey after all these complications have set in. And when a doctor wants to address the underlying causes, they don't give doctors the time or resources to even talk to patients to get into the deep issues. Maybe we need to treat more diabetes with cooking classes instead of just throwing insulin at people. Maybe we need to treat more high blood pressure by addressing their sleep quality, because poor sleep increases vascular tone. And getting into stress instead of just throwing antihypertensives. Maybe we need to treat more school lunch programs, treat more diabetes by addressing school lunch programs instead of just, throwing Ozempic at them. The American Academy of Pediatrics now is pushing to put every 6-year-old who's overweight or obese on Ozempic.
Meaning the rest of their life. It's a weekly injectable drug, right? So, and if you get off it, you become obese again.
It's incredible. These giant blind spots. If we zoom out, we've poisoned the food supply. We've engineered addictive foods. We diagnose kids with mental health diagnoses like crazy. And then we medicate them when they come in sick and suffering. I mean, we're converting America's children into a generation of patients. We can't keep going down this road. We have the worst health outcomes of any developed country, despite our massive investment. And, we've created a lot of millionaires in healthcare, a lot of non-patient facing millionaires in healthcare. But at no point does anyone stop and ask, what are we doing? Can we do it differently?
Okay. So, I mean, this sounds like if I didn't know already, and I hadn't read your book, and that I might be listening saying, well, is this new? Is there evidence? Like, medicine's done pretty well. Life expectancies have generally been going up for a century or more. Medicine's gotten better. But in fact, this is not new, is it, Marty? There's actually evidence in your book, and let's go through some of the examples so folks can hear. But it's not new, is it? This medicine's been like this for a while.
Yeah, this sort of hubris of a medical establishment has been there for a while, and censorship too. If you look at the guy who said, no, it's not natural fats that's causing heart disease, it's added sugar, and it's driving inflammation, and heart disease is essentially an inflammatory condition that enables lipoproteins to deposit. So the censorship may be more overt now with big tech, but there's actually a groupthink mentality in every industry. By the way, there's a psychology to it. We see it in politics and business and in medical science too.
Well, Marty, let's go through that example, because that's a really important and striking example, right? So I'll just tell you a story, the true story. This is my dad had diabetes, type 2 diabetes, diagnosed when he was 40. When he was 48, he had a heart attack. And then when he was 56, he had a second heart attack and died from the heart attack. After he got diagnosed, he was a very disciplined man. And he went on, this is in the late 70s, mid 70s, he went on this, the diet that was recommended for diabetics there, which is essentially a zero fat, high carb diet. Limited calories. And he was we did not eat well after he got the diagnosis of diabetes in our family. So, he had oatmeal for breakfast, nothing else adorning it, no fruit or anything. He had rice and dal, which is this dal is like this lentil curry that Indians like. Yeah. And then for lunch, and then he would have the blandest little bit of chicken or something, and rice, mostly rice for dinner. And that was it. That was his diet from age 40 to age 56. And he lost weight. He lost a lot of weight because he was very disciplined, but he had 2 heart attacks. the advice that he's following, the diabetic advice, essentially to eat high carb diet for a disease that is a disease of processing of sugar. Of course, carbohydrates are processed into sugar. How did that happen? How does that come about? How does the story tell the story that you tell in the book about the discovery of about diets, LDLs? I think it's a really interesting story for folks to hear.
First of all, it's so tragic even to hear you describe what happened, because it's okay as a scientist to get something wrong, but you've got to immediately correct your position, or commission when the truth comes out, or commission the study to get the answer. So, and I like to tell stories because I think when people know the real backstory of some of the medical dogma that's still out there today, and I'm not talking about fringe people, I'm talking about mainstream medicine. I'm talking about the nutrition community is still recommending a low-fat recommendation. There was just a directive out of the Biden administration to reduce the fat content in school lunch programs. The irony, here you have milk, which has natural fat in it, and we take out the natural fat it's not bad for you. We take it out and we add sugar. In these little cartons, I'll have 20 grams of sugar. And so this all began. So anyway, I like to tell the story because I think people remember it. If you just tell people the truth about health, it's like a textbook. It's boring. But if you tell people the backstory, they remember it. So there was a guy named Ancel Keys, Dr. Ancel Keys, after Eisenhower had his heart attack. And Ancel Keys wanted to be the expert and tell the world, since he was the authority, that what caused the heart attack. The country really didn't know what a heart attack was. They were rare. And he said it was because he ate too much fat and the fat built up in his, coronary arteries. Well, it wasn't true, but he had a shoddy epidemiologic study that he had published called it was at the time 6 countries, and then it was later called the 7-country study. He omitted all these countries from his study in order to make the data fit his hypothesis. And then they put President Eisenhower on that strict diet they put your dad on, right? Like no fat of any kind. It was brutal. They did it to my Uncle Sam. That's his name, Uncle Sam.
I feel like I know your Uncle Sam from your books. Anyone reading it, just put in the comments about your warm feelings for Marty's Uncle Sam, because
he's an amazing guy. He's 92. He went with a desert patch with no saturated fat, no eggs, the one food he loved the most, for over 30 years, because the American doctors, when he immigrated to the United States, demonized natural fats and scared the crap out of him. And now he's back to being 92 years old, going to the pool every morning and eating his eggs every morning. And so I love seeing him do that. But Ancel Keys convinced the world. He was politically savvy. He was really the Dr. Fauci of his day. And he started suppressing people who had different ideas through his networks. This guy, John Yudkin, a famous physiologist, said, and even wrote a book, said, no, it's the sugar. It's the ultra-processed and refined carbohydrates, the sugar in the diet that's causing this problem. And Ancel Keys said, no, it's the fat. So they started a study at the University of Minnesota to prove once and for all that fat caused heart disease, that natural fat, saturated fats.
This is in the 60s, right? They started this.
They started it in the 60s. It went on through the 70s. And in the 70s, they got the results, but it was the opposite of what they were hoping for. More heart attack deaths in the low-fat group. And so they suppressed it. They didn't publish it for 16 years. And my friend Gary Taubes tracked down one of the senior authors before he passed away and asked him, why didn't you publish this for 16 years? And the guy basically said, look, we were just disappointed in how the results turned out.
It's striking to the timeline. I've actually had Gary on this show before, and the timeline is striking, right? So start the study in the 60s. You have a 16-year-long longitudinal study, pretty high quality, if I understand it, finds the result that low-fat diets raise the rates of heart attacks.
Yes.
My dad gets diagnosed with diabetes right around then, goes on the low-fat diet. it's hard not to like go back and say, well, what if they had actually allowed that study to be published, actually, and allowed it to be published and to change the recommendations. It's hard to, anyways, I think that story could be repeated hundreds of millions of times, maybe over and over. It's just you go back and look. It's not just that these are academic results to be stuffed in a drawer that change the reputations of one person or another. Like, who cares about that? Lives are at stake. Like, actual regular people's lives are at stake here.
My dad, who I mentioned is a physician, still avoids natural fat because it was beat into him incessantly. Even though there were two other major studies, including the largest study ever done in medical history. And all three studies failed to show the connection between natural saturated fats and heart disease.
Can you describe what happened to the people that spoke up? Maybe you'd call them fringe epidemiologists of the yesteryear. I don't know. Yudkin, and then there's Kathleen Flegel and others. What happened to those folks when they tried to say, well, look, the work we're doing, the work we're seeing, the rigorous work doesn't lead you to the dogma that the American Diabetes Association has or American Heart Association has for low-fat diets?
Well, they would railroad their careers. Yudkin had his lab taken away. There was a physician who was highly respected, who was one of the main doctors for the what's sort of known now as the Framingham study, this giant, one of the largest trials ever done, supported by the government. And he had basically seen the data that there was no increased rate of heart disease among those who had a low-fat diet, they didn't lower among those who were on a standard American diet. The low-fat diet had no benefit, and this is before PubMed, and he wanted to make these results available, and they basically demoted him and ruined his career. Eventually, the data came out. And the thing about science is the truth always prevails ultimately. And so you look back and it was this, and I don't want people to think, oh, that was the old days. Now we're enlightened. Now we have a nice
hold on. I want to go through some more examples of the old days first before we go to that. Because So okay, let's move from diet, from low-fat diets to peanut allergies. Mm-hmm. Well, we'll stick with diet for just a bit. I think that's the first chapter of your book. So I remember when I was little, there was no such thing as peanut allergies. As best I can remember, no kid I ever met when I was little had a peanut allergy. But when I had my first kid in like the year 2000, the first thing they tell you is be careful with peanuts. Yeah. And, like peanut butter is like, that's just a normal thing growing up for me. I was like, I basically ignored that advice. Don't tell my pediatrician. But we just ignored it. And it went fine. But a generation of kids avoided peanuts when they were babies. Well, how did that come about? And what evidence was there? What actually happened with that?
Well, the American Academy of Pediatrics felt like they needed to tell parents something to, when they were asking, how can we avoid a peanut allergy in kids, even though it was fairly rare. And most peanut allergies were mild. So the American Academy of Pediatrics Committee on Nutrition, and I interviewed some of these folks, they didn't know. They had no idea. But they felt like they had to say something, even though I told them.
Like late 90s or mid-90s, something like
that?
Late
1990s.
Yeah.
And then in 2000, they issued this recommendation. And I told them, if you don't know, you can say we don't know. You don't have to, because they said, oh, we had to tell them something. No, you don't.
You don't have to say anything.
You can say we don't know. You can let different scientists put their hypotheses out there. You can study the question with a randomized trial. So they didn't do the study, and in their arrogance, they put out a recommendation that got translated into every pediatrician, telling every parent in America, avoid all peanut products, peanut butter, in ages 0 through 3 altogether. Total peanut abstinence. And if you abstain from peanuts, that will reduce peanut allergies. Well, guess what? They got it perfectly backwards. They forgot about a basic principle in science called immune tolerance. The immunology community was very familiar with it, but they didn't consult them. And so they put out this dogma, and instead of reducing peanut allergies soared, including a new type of allergy that became common, severe anaphylaxis, that is, allergic reaction from a kid just being near a peanut. These are real. These kids are suffering. I mean, life is miserable for some of these kids I interviewed. And as the peanut allergy rates went up when they made this recommendation, they felt, well, people are not compliant. There's anti-science parents out there who are not following our recommendation. We have to drill down harder and double down and get them to
that
comply.
Was me. I didn't follow for my kids, but it was one of those things where like it just made no sense. It made no immunological sense, and it contradicted our family we had peanut butter. It was just part of our so we gave our kids peanut butter, but I don't think most of people were like that. Most families listened to this dietary advice.
Look, a lot of people said, hey, there's this thing called the dirt theory. The more you're around an allergen, the more your body's going to tolerate it immunologically later. Even some immunologists who had kids were like, I'm not following this. And I interviewed some of these physician immunologists who were totally defiant. And some were pediatricians and were defiant and told parents to introduce peanut butter at 5 or 6 months of age, or as soon as a kid could eat a little bit, not entirely.
Of course, yeah.
And none of their kids got peanut allergy. One of these guys, none of his kids in his practice got a peanut allergy, but the American Academy of Pediatrics kept singing this song without doing any science. They never really commissioned the study. And 15 years later, it got done. Just about 7.5 years ago, this study was published in the New England Journal of Medicine, randomized trial. Easy, embarrassingly simple. They took 640 kids, randomized them, radically 8-fold difference in peanut allergies and the severity of the allergy. It finally ended this whole controversy. They were wrong. And to this day, because we can't just dig ourselves out of this peanut allergy epidemic overnight, there are essentially no peanut allergies in Africa and many parts of the world, but the United States leads the world in peanut allergies.
Right. Our medical establishment caused this epidemic of peanut allergies in the U.S., right? They caused this massive problem. And it's not just that you can't eat peanuts on an airplane. Like I'm old enough to remember where they actually would hand peanuts out, Marty, on an airplane. That's one thing. But actually, there were kids that died because of what the AAP said. The advice that they gave. And there's still to this day, I think a lot of parents that still think that giving peanuts to their very young infants to their young infants as soon as they start to be able to eat solid food is somehow like a terrible bad thing. I mean, that advice still goes around.
When you don't know something and you put it out there with such absolutism, and we got a peek of this during COVID. COVID was just a peek into how our broader medical establishment has operated on so many health issues. And then you get it wrong. And instead of apologizing and setting the record straight and reconciling with the same vigor by which you put out the initial recommendation, you lose trust. People don't trust you. They realize you've been lying to them, or you've been misrepresenting your opinion as scientific fact and abusing your authority. This
is the same AAP that put out advice during the pandemic saying that there's no possible harm of development, the developmental harm that comes from masking very young children, toddlers.
And,
what study did they have? They had no evidence, Marty, like literally none. I went looking. I don't know what they were thinking.
I personally think pediatricians need a new association. The American Academy of Pediatrics was saying schools should be open, schools should be reopened in the fall of 2020 when you were working on the Great Barrington proposal with Martin and so many others. And then the second Trump said it, the AAP changed their position. And so this is a group that's been hijacked by politicians, in my opinion. And so it's disappointing because when you're so absolutist about something you don't know, then what happens is you activate all these doctors on this cause that's a futile cause. For example, one of the futile causes they activated doctors on was to block peanuts from being used in world food programs throughout the 2000s. a peanut is one of the most amazing things to address world hunger. It's inexpensive, loaded with protein. You don't need refrigeration. You can transport it. It lasts forever. And they were using their dogma to block and to try to block peanuts used in food addressing world hunger. And to this day, their dogma has resulted in the WIC program not covering peanut butter for infants. So we're still living in the shadows of this dogma.
Hi, everyone. A quick recommendation. I just saw a great film on YouTube called Medicating Normal. It's about the growing trend to medicate mental distress with powerful psychiatric drugs like Prozac, Xanax, Seroquel, and Adderall. For some people, once on these drugs, they're almost impossible to get off, and they have devastating side effects. The film tells the story of people whose lives were ruined by taking these common prescriptions. Watch a trailer and the award-winning film on medicatingnormal.com. That's Medicating Normal, medicating with an ing at the end, normal.com. Our show notes and newsletter will have information on how to find the film. There's also a YouTube channel. Don't miss it. Check out the link in the description below. Thanks.
Yeah. I mean, anyone who's listening, and you haven't had Bamba, B-A-M-B-A, you should go try to find some. I don't know if you can you find it in the States? I don't think I've ever. Oh, you can. Okay.
It is. Yeah. It's on Amazon.
Oh, I see. Okay. Where all the good things come from, I guess. Okay. So, let's do another chapter from your book. When kids come into the world, the story that you told, I actually had the same almost exact experience in medical school. This is like in the mid-90s. I'm a medical student. One of the rites of passage of medical school is that you help deliver a baby. Yeah. And you're sitting there with your shaking, thinking in your head, the only thing that you could go wrong is if you drop the baby as it comes out, right? That's right. And you tell the story very well. But the first thing that happens is this is in the mid-90s. You clip the cord, you clamp the cord, and you clip it for the umbilical cord for the baby to the connection to the placenta, and then you take the baby away and give it not to the mom, but to a whole team of pediatricians who are there. They're going to poke it, prod it, clean it, and so on. Of course, this is not. It's kind of. I mean, now to be fair, there's been significant improvement in obstetrical outcomes over the course of the last century or more, right? So it's not like in principle you think that this is the wrong thing to do. And yet, it seems like a cruel thing to do to a baby. I remember when my daughter was born, it just felt wrong watching it as a parent, as opposed to being sitting there as a medical student with my hand shaking. What's the evidence on that? What is like? Is it right to take babies away from their moms almost immediately? What did you find on this?
Well, for almost all of human history, babies, once they were delivered, were given to their mother. There was a natural instinct to hold the baby. And the babies were warmed in a natural incubator, held skin to skin against the mother. Kangaroo care, we call it. And the babies were more likely to breastfeed, which is important for their microbiome and future health outcomes. And there's something magical that goes on between a mother and a baby, the bonding. And what happened was the medical community in the post-World War II era, in the 1940s and 50s, had a transformation. There were now antibiotics, and antibiotics reduced maternal infections that helped reduce mortality. And there were some real advances, but when antibiotics were introduced, doctors took on a new role in society. Before antibiotics, we as doctors had almost no tools. We had basically a saw to do amputations and a lancet to draw some of your blood to try to remove the bad humors. And doctors weren't disrespected, but they were kind of viewed like a barber. As a matter of fact, surgeons were barbers. They were called surgeon barbers in the UK. There just wasn't a lot you could do. But then once we had a magical pill, an antibiotic that we controlled and only we could administer, doctors had a new position. They formed their own society. They began to wear white coats. Hospitals were now places where technology was dazzling the public, incubators and iron lung machines. And doctors began to take on this unquestioned authority. They took a very paternalistic attitude. They would separate babies at birth and keep them in their pen to poke and prod and study for a routine of 10 days. A normal, healthy baby separated from the mother for 10 days. And this continued. This culture of paternalism continued. When my little sister was born in the 1980s, I remember asking my mom and dad after my mom delivered her, when's our little sister going to come home from the hospital? And they would say, well, the doctors haven't released her yet. She was normal. They were born that term. They would just keep her and keep her. They kept her about 3 days. And we'd go to the hospital, look through the glass. There she is, third row in the back, second from the end. You know, it's like, what are they doing with our sister? And this culture of medical paternalism still looms large. When home pregnancy tests were developed, the medical establishment insisted, no, we can't let women find out if they're pregnant on their own at home. They can't handle this information. We have to tell them. When HIV tests became available, medical establishment blocked people from getting the results on their own. They have to come in and we have to tell them the results. And during COVID, when I wrote a piece in the Washington Post calling for home COVID testing, long after there was...
That was in March 2020. I was impressed.
Well, that was beyond, once we knew there was broad community seeding, you're not going to trace and block and contain. Then sorry to get off track, but just on that point about home testing, this is something I noticed that it took a very long time for that home testing to be approved. And part of the reasoning, I think, of the public health establishment was that they wanted to track every case. They wanted to contact trace. They wanted to quarantine. They wanted to treat it as if COVID wasn't a airborne, easily infectious disease where there's no way of knowing what 40% asymptomatic rate or whatever it was. There was no, and so if you allowed home tests, the public health establishment wouldn't know, even as the people themselves knew. If we'd had home tests in 2020. It would have been much easier to do focus protection. You test yourself before you go visit your elderly parents, for instance. It would have saved lives. But again, you saw this paternalism in the medical culture. Same paternalism that said we can't tell people about natural immunity because that might create vaccine hesitancy. This paternalism, really treating people like they're subordinates to the ruling class. And in the case of the COVID home testing, they really felt like we have to have a total handle on this. People won't reliably tell us if they tested positive for our tracking systems. And we have to have an army. I remember Ashish Jha calling for hundreds of thousands of government-hired contact tracers. And when I got called from these contact tracers, go to a restaurant, they'd say, oh, someone at the restaurant tested positive 3 days ago. Where have you been, Marty Makary? I'd play with them and I'd say, I took the L train through Manhattan and got off at Grand Central, then took the Amtrak. I mean, it was insane. If we just hired a million contact tracers, we could finally stamp
out the disease. I mean, of course, the contact tracers have to sit in a room together, call on the phone bank, calling everybody. I remember there was this story, just in the LA Times, where they were just so distressed that immigrant were not picking up the phone or talking to the contact tracer because they were afraid they're going to get deported.
Right.
And often when the cases rose, it would be 3 weeks before the contact tracer would call somebody that got COVID. I mean, who have you been in contact with the last 3 weeks? I mean, it's just ridiculous. Who have you breathed near?
It's a tool designed for the beginning of a pandemic when you can contain it, not when there's broad community transmission seeded.
Okay, but let's get back to the kangaroo babies. I sorry, I took you off track because this is it's a really important and a very cute story actually. So with a fantastic hero in the middle of it. So go on. Go on with your story.
So there's a doctor from India where they really didn't have enough ICU beds. They didn't have ICUs. And then if the sort of makeshift ICUs, they couldn't accommodate all the preemies. So they would have the moms hold the babies and they would use basic techniques that try to restore a natural delivery in the hospital. These were doctors, like delayed clamping of the umbilical cord. It kind of made sense, right? Why were we cutting the umbilical cord as students? The second we see it, there it is, cut it. It's pulsating. It's delivering healthy blood to the baby that has fetal hemoglobin and oxygen and stem cells and antibodies. And why are we cutting it? And just so we can whisk the baby off under some French fry light in the corner to poke and prod, the baby doesn't need to be rewarmed. They were getting a warm blood transfusion directly into their circulatory system. So she realized, hey, we got to do delayed cord clamping, skin to skin time, first hour colostrum to encourage breastfeeding. And you don't need to wash the babies and remove that sort of protein coat that has some thermal protection and seeds the bacteria, the microbiome. And they would do everything possible to avoid a C-section that also alters the microbiome. So she did this protocol at her hospital and started having amazing results. Like the NICU utilizations went down. The babies required less vasopressors and their blood pressure was more normal. Even the blood sugar was more normal. And when I heard that, I said, wait a minute, Dr. Shiravulu, I understand the other mechanisms, the blood pressure, heart rate. Why would the blood sugar be more normal with this protocol? And she explained it made sense. The stress hormones are not spiking. And when
being
the
next to
baby's
mom reduces the stress of the baby. Actually, probably also reduces the stress of the mom.
probably.
And the dad looking on, I bet.
Yeah. So it's amazing, and I think one of her colleagues told her, we're not going to do some African protocol here, and she said, this is at her hospital, Baylor Scott and White Hospital. She said, well, if Africa's doing something right, then we can learn from Africa. She's
Good
kind
for
of
her.
feisty. Yeah.
Okay. So Kangaroo Kids, one more story of the past, and then we'll go to the present, and then we'll talk about the future. So this is a very sad story about HIV tainted blood in the early days of the HIV pandemic or epidemic. When HIV came out, it very quickly became clear that the most directly affected group were gay men. But there were these other cases that you would see that would pop up of children sometimes getting it, especially hemophiliacs. But it took a very long time for the folks who run the blood banks of the U.S. to admit that it was possible that blood for transfusion, the blood that you go and donate, might have been infected with HIV. So can you tell that story?
So I met this amazing guy doing this research named Dr. Don Rucker. He was a resident in California, and he went to what they called sort of the politically incorrect term, but this was what they called it at the time, the Gay Diseases Clinic. It later became known as the HIV or the AIDS Clinic and then the HIV Clinic. But in that clinic, they would see people with this rare constellation of pneumocystis and immunosuppressed related infections. And these were primarily people who were gay men and IV drug users from both communities, sometimes from both. And what he noticed was that whatever this infection was, this is way back in 1981, before really the attention around AIDS. Whatever this was, whatever was in pathogen was creating this AIDS-like constellation of symptoms must have been bloodborne because IV drug users were getting it. And so he notices some of his patients from this AIDS clinic donating blood. Like he recognizes the people when he's out for a run. And at the time, the blood bank would pay people, and that's how they would support their drug addiction and buy drugs from the money they got from donating their plasma. And you could do it frequently. And so he was just like, it was so obvious to him, this is bad. This, whatever's going on here, it is probably bloodborne, and they're contaminating the blood supply. And he wasn't alone. This was in 1981. It would take another 6 years for the FDA to require universal testing of the blood supply. And along those 6 years, we had the public health establishment. If you think they botched COVID, it was the same thing the public health commissioner of New York, saying that, the risk of HIV from a blood transfusion is the same as an earthquake. Fauci said, is it possible? It is, possible. However, the risk is extremely low. Right.
How
and
did he
all
know?
this,
There was no studies.
they had no idea. They had no idea.
Like these confident statements made in the absence of evidence it's just striking. And in fact, just to close the loop on this, it's not that took 7 years to get a test.
Right.
The test was available almost immediately.
Yeah, almost immediately. Stanford doctors had identified a way to just look to see if you had a low white blood cell count, because blood cell counts that's a test that's been around for decades. And this guy was laughed out of the Grand Rounds Hall, I think at UCSF. He was speaking to a group of pathologists. He was called homophobe and racist. He was told, you can't do this. But at Stanford, they actually screened the blood supply using his test, and they saved many lives. But because of the hubris of the medical establishment for years, when they didn't know, arguing with such absolutism that the blood bank was safe, they killed a generation of Americans with hemophilia, severe hemophilia. You didn't even see them in the hospital for like 15 years later. We killed a generation of people with severe hemophilia because they require frequent blood transfusions. Many other Americans, tens of thousands, including Arthur Ashe, the famous tennis player and civil rights leader. The stadium at the U.S. Open's named after him. And so it was just incredible, because it's not as if, people say, oh, you make the best decisions with the information you have at the time. No, they ignored the voice of practicing physicians who were saying, please listen, there's significant risk here.
Okay, so let's this is all in the past, right? We've learned much better now, Marty, and
we're now enlightened.
We know everything we now believe in medicine is 100% true, right?
Right. This is the fallacy, right? That somehow we're above mistakes of groupthink, that the small central planners of health recommendations in the government are now open to civil discourse, and we don't have this sort of arrogance. But that's the furthest thing from the truth.
So you have a fantastic chapter near the end of the book where you go through 10 items that you say are maybe blind spots. I mean, certainly blind spots in the sense of we don't have enough investigation. The medical community is too hidebound to actually want to investigate it. Researchers are afraid to go into it. They can't get funding. So I don't want to go through all 10 because I want people to read your book. So they could. But let's give a teaser. All right, fluoride in water.
Yeah. And,
what is so I remember in the 50s, there were these John Birchers that were really upset that the public health was going to put fluoride in water. They're called conspiracy theorists. In many ways they had some crazy ideas, but the dentist said, look, you have to put fluoride in water. It's the only way to get rid of cavities. Completely safe. Every single, 2/3 of all municipal water supplies have fluoride in water, something on that order. So your kids and you are probably drinking fluoride in water today, if you're listening to us.
Yeah,
what's the evidence on that?
Well, the observation was that fluoride in the drinking water reduces the risk of cavities, and I think it does because fluoride kills bacteria. But if it's killing bacteria in the mouth, what's it doing to the microbiome? That is the garden of millions of different bacteria that live in harmony in the gut. It may very well be affecting gut health. And secondarily, there's an entirely different mechanism that some doctors are concerned about, and that is it may accumulate in a learning center in the brain. And studies in top medical journals like JAMA have suggested that there's lower IQs among children that are raised with fluoride in the drinking water. So there's two mechanisms now to say, hey, maybe Europe has it right. They only fluoridate about 3% of their drinking water, whereas it's the vast majority of the drinking water in the United States. So here's a good example where we have celebrated, yay, we put fluoride in the drinking water. It's still on the CDC website as one of the 10 greatest public health accomplishments in modern history. if you go to their website, it turns out we may have gotten it terribly wrong.
I don't know what to say. I mean, it's one of these things where, like, as a medical student, I was certain that the evidence on this must be perfect. I hadn't had time to look, but it was, it'd be very low on the list of things to look at because people were so certain it was right. I mean, I had all these other things that instead I was like, I'd go look at. And yet something so supposedly rock solid as that, it turns out the evidence is actually quite poor. I mean, I don't know that it causes IQ collapse. I mean, it's hard to tell sometimes from these observational studies. But do you know of any randomized evidence to like investigated that question?
I know, but this was a pretty elegant study that was published in one of the JAMA journals. And the two dentists that I respect the most, they read everything out there on not just dentistry, but health and wellness. Both of them have pretty sophisticated, expensive systems in their home to remove the fluoride from the drinking water.
Well, so this is the issue, right? So there's a standard of proof that you might have for a drug or an intervention, and it's. I mean, for me, it's very high. I mean, maybe it's not as high as it is for like Vinay or something, but like Vinay Prasad or something. But it's very high. Like I want randomized evidence, and good observational studies are certainly they help me decide things. Absolutely. Right? Suggestive. But here what you have is a population-wide intervention undertaken with none of that.
Yes. No consent. I don't know if you want to talk about hormone replacement therapy, but there's.
Oh yeah, let's talk about that's. I guess it's still not quite in the past. It has an interesting past history, but it's still something that is current. So yeah, so let me tell a little bit of the story of this. And this actually happened in med school again. Everything bad happened to me in med school. In fact, I was just out of med school. My mom called me, and she was in menopause, and she was having hot flashes. And she went to the doctor. The doctor said you get estrogen, progesterone, hormone replacement therapy, like just a standard thing. And she calls me up and says, "Should I take this?" And this is like medical school. This is before the Women's Health Initiative. And I say, yes, of course you should take this. And I gave her the usual line about, well, there's some trade-offs in your health, but it probably doesn't have any impact on your lifespan. It'll certainly address all of the symptoms you have. Yes, go ahead and take it. Then the Women's Health Initiative, which is a massive randomized study of the hormone replacement therapy, included a large number of women, who are undergoing menopause, randomized into whether they should get or not get hormone replacement therapy, comes out, and my mom listens she learns the results on like Good Morning America, where they're like, "This is poison, don't take this." And she calls me up and says, "Why are you trying to kill me?"
Yes.
Mom, how am I supposed to anticipate what a randomized trial I said, right? So, and she went off of it almost immediately. She went off of the hormone replacement therapy almost immediately. In fact, I did a study where I looked, it turns out that shortly after that Good Morning America appearance, it was about 30 or 40% of perimenopausal women that were on hormone replacement. Shortly after that, it went down to like 2, 3, 4%. Basically, doctors stopped advising women to take this therapy.
Oh, the WHI study led by this NIH professor, this NIH scientist who was also a bit of a Dr. Fauci of his day, he declared that hormone replacement therapy, that is when a woman goes through menopause and they stop producing their own estrogen and progesterone, it's then replaced with estrogen or estrogen plus progesterone, what we call hormone replacement therapy. This doctor announced that they did the largest study in human history, $1 billion taxpayer-funded study, and that it found that hormone replacement therapy causes breast cancer. He didn't release the data. A week later, the data trickles out, and by that time, the media had run with the headlines. When you look at the actual numbers and the statistical tests in the study, it's unbelievable. There was no statistically significant increased risk of breast cancer, and there was no increase in breast cancer mortality.
You include the table in your book, for me, this is like it was like a dramatic thing, right? I don't know if other readers will pick up on this, but the confidence interval is a mile wide around that question about that. Does hormone replacement therapy in this randomized data increased breast cancer. The answer from that study is, I have no idea.
Yeah, I mean, you cannot conclude that it causes breast cancer. And ironically, in the group that took estrogen alone, they had a lower rate of breast cancer and breast cancer mortality. And when you put out the fear, when you dangle fear out there that this is going to cause breast cancer, it turns out there was a backroom meeting of the investigators where they kind of bullied them just before the publication. A bunch of doctors said, you can't put that out there. If you put something as sensitive as breast cancer in front of women saying you could get this if you take hormone therapy, they said, you'll never be able to undo that fear. You will never be able to put the genie back in the bottle. And they were right. There was no statistically significant increased risk of breast cancer, despite it being the largest study ever done, randomized trial. Many other studies. Here's the thing, Jay. The irony is that there is probably no medication in the history of modern medicine, arguably with the exception of antibiotics, that has improved the health of a population more than hormone replacement therapy after menopause. When it started within several years of the onset of menopause, women who take hormone replacement therapy live an estimated 3.5 years longer. The rate of cognitive decline goes down by 50 to 60%. The rate of heart attacks goes down by as much as 50%. That's the number one cause of death in women. If a woman falls or is in a car accident, they're far less likely to need surgery or break a bone. Their bones are stronger. And on top of that, it alleviates many or all of the symptoms of menopause, which are significant. So women live longer and feel better on hormone replacement therapy when started within several years of menopause. And tragically, 50 million women, and to this day it continues, have been denied hormone replacement therapy because of the dogma that it increases breast cancer mortality when data has never found that to be true.
It was striking reading your account of this in the book, because you actually went and interviewed some of the people that were in this infamous meeting that led to the Good Morning America press release and all that. And there were people in the meeting saying, "I'm not comfortable with this. Why?" The investigators in the Women's Health Initiative, they were uncomfortable with the sort of the stamping out of hormone replacement therapy. And to this day, they're still sore that they've been railroaded, forced essentially to sign on to something that the data that they themselves had generated and analyzed did not show.
It's amazing. This guy, the lead guy, really bullied everyone. He called them to a meeting in the Sofitel Hotel in Chicago just before the announcement, and he said, "Hey, you can throw out the agenda. There's been some new developments. We found that there's a higher rate of breast cancer. Here's the manuscript. We submitted it for publication, and it's been accepted. You're listed as co-authors." And the scientists there, a bunch of them are like, whoa, what is going on here? This is totally unethical. You submitted an article, and so the lead scientist hands it out, and these doctors are reading it saying, you can't say this causes breast cancer. And this shouting match erupts. And I interviewed people in the room. It's unbelievable. Well, the lead guy, who goes on to say anyway that it causes breast cancer in the press conference that the media ran with, he went on the cover of Time magazine. He's celebrated. He just published another follow-up to this study that kind of continues the same stuff. And 80% of doctors or so today still do not want to prescribe hormone therapy and believe that it causes breast cancer because of the dogma that he circulated. My mom fell. She's not in the medical profession. And she went through menopause right around this time. This was 22 years ago when the announcement was made. And the doctors did not offer her hormone therapy as she should have gone. She was a good candidate. She doesn't have a history of blood clots. Or endometriosis or endometrial hyperplasia. She would have been a great candidate, like the vast majority of women that go through menopause. And she was not offered it. Well, she fell and she broke some bones. And I showed it to I showed the film to my orthopedic friend, and he said, it's borderline. At her age, you might be able to not do surgery, but it's really borderline. If her bones would have been a little stronger from being on hormone replacement, she wouldn't have needed what ended up being a cascade of procedures Another surgeon eventually said, no, in my experience, you really do need surgery here. And I sort of took a vote among orthopedic surgeons. They said it's real borderline, but yes, she really should have the surgery. She had the surgery. Well, of course, she was immobile. I mean, this is a massive health setback, and it was entirely avoidable. I couldn't help but think of that Women's Health Initiative misinformation as my mom was dealing with this.
Okay. So Marty, I'm not going to ask you to give medical advice to women. I think people probably can tell what you would suggest. Go talk to your doctor and see if it's right for you. But make sure that your doctor understands what the evidence actually says.
That's right.
When they give the advice. So is that a general rule for what patients should do with this fact? I mean, because what should patients do? If doctors have these blind spots, how much can they trust their doctors that the advice that they're getting from their doctors really is good advice? And how do they navigate this?
Well, if you're in an emergency, if you're bleeding, or if you get shot, do whatever the doctor says. We don't want to create cynicism. But when it comes to chronic illnesses, when it comes to long-term decisions where you have the luxury of understanding the different options out there, it's maybe good to get multiple opinions. If your doctor tells you, you need to do this just because I'm the expert, run for your life. I give people in the book some guidance where you can ask a doctor, how do you feel about hormone replacement therapy after menopause? If they say, well, it causes cancer, keep looking for another doctor, because there's two types of doctors I meet in the medical establishment. Those who are open-minded, who individualize care to patients, who consider all forms of data, both their clinical wisdom and scientific studies. And then there are those who just recite the recommendations of an American Academy of Pediatrics guideline, for example, like it's a catechism. And those are the doctors where I think sometimes you would hope that they use more of their own, independent thinking. Now, many of the national guidelines are good guidelines. I'm not, criticizing all of them, but it's nuanced, right? It's nuanced, and you want a doctor who listens to you. Someone said, hey, my doctor won't prescribe hormone replacement therapy because they say it causes breast cancer because of the 2002 Women's Health Initiative. And in that, for someone like that, I say you can read my book and I go through the scientific literature, and you can maybe have a conversation with your physician, see if they're open. What makes a good doctor? I tell this to all my students. What makes a good doctor is not how many intermediate molecules of the Krebs cycle you can recite on demand in the trauma bay. It's your humility. It's knowing your limits. It's saying, I don't know, and that's the right answer.
I mean, that sounds like fantastic advice for patients. But what's your recommendation for reforming medicine so it becomes more open, just generally, like to research, so that it doesn't become beholden to essentially a small number of voices, sort of a Fauci effect within each area of medicine? How can medicine and the research into medicine change so that this kind of groupthink won't happen in the future?
I think it's important for people to understand the psychology of groupthink. It's easier when you surround yourself by people who agree with you. And in medical science, we have to fight that urge, because science is all about challenging deeply held assumptions in the field. And we don't want to create cynicism, but asking questions is not the problem. It's, in fact, the solution of how we discover new findings. It's how we test medical dogma. So I think in general, we need to have more fresh ideas. We need to, we have an old guard. The people who control the medical journals, they serve terms longer than King Henry VIII and the president of Zimbabwe, Mugabe, 30 plus years. They don't let go of their power. And some of these deans and department chairs, it's good to have young, fresh ideas. Part of diversity is age diversity. Have these fresh ideas, challenge the deeply held assumptions, and that's how we all grow. That's healthy. That's good. But we're not going to get there with the old belts and suspenders professors at the NIH telling us what we are and are not allowed to study. We desperately need to study food as medicine, the microbiome. There's one woman at the NIH in the microbiome unit doing great research. That should be a giant section. That's like, it's central to health. pesticides, environmental exposures. We need to study what causes cancer, not just the chemo to treat it.
Well, Marty, I've kept you for over an hour. I feel like we could talk for several more hours, but instead, let me just recommend to listeners, go buy Marty's new book, BlindSpots. If you enjoyed listening to these stories, enjoyed may not be the right word, but like we're interested in listening to these stories, please go buy Marty's book. It is a fantastically well-written book. What you'll read will instruct you and also maybe infuriate you a little bit and help you to navigate better the conundrums of your health and your engagement with the medical care system. Marty, thank you for coming on. Really, it's been a pleasure to talk with you.
Great to see you, Jay. Thanks so much for the conversation.
So this is Professor Jay Bhattacharya for the Illusion of Consensus podcast. Until next time.